Good morning, my name is Alex Casey and this is my complex case scenario presentation on DW. DW is a 79-year-old male whose primary condition is bilateral knee degeneration and a stroke suffered in 2011. His secondary conditions are type 2 diabetes, hypertension, obesity in class 2, and post-traumatic stress disorder. He is currently on Actonel once a month, Astrix 1 daily with meals, Diabex 1 in the evening, Lipitor 1 daily, Movicol 1 in the evening, Sachet at night, and Toptrol. The client also recently developed a corn under the left hallux, which he reports pain in the toe-off phase when walking. He also reported shoulder pain recently in any pushing exercises. The client can only exercise at home due to his PSD and his inability to perform his ADLs. His wife is also his main caregiver. His goals are to improve his ADLs, weight loss, and exercise away from home, in public, and possibly at a gym. His initial assessment weight was 120 kilos and his final assessment weight was 120 kilos also. This places him in the obesity class 2. His waist to hip ratio in initial assessment was 1.01 and his final assessment was 0.97. A score over 0.94 greatly increases the risk of coronary artery disease. The initial assessment results of the static unipedal stance test was 30 seconds on the left foot and 17 seconds on the right foot. In the final assessment, the scores were 14 seconds on the left foot and 21 seconds on the right foot. There was expected lower score on the left side due to the stroke affecting the left side of the body, and the normative values were 18.2 seconds, which the right leg scored near. In the initial assessment results of the 30-second arm curl test, the left side scored 16 reps and the right side scored 17 reps. The final assessment, the left and right side both scored 11 reps. Although the reassessment had lower reps, the technique was much better and would rather that technique over the initial assessment results, which were around the normative values. The 30-second push-up test using a wall push-up was only added in the reassessment, so there were no initial assessment results. This was the first attempt at the assessment and focused on shoulder motion during fatigue. He scored 30 reps. In the 30-second sit-to-stand test using a chair, he scored 30 reps in his initial assessment and 11 reps in his reassessment. Although there were fewer reps in the final assessment, similar to the 30-second arm curl test, even though he had lower reps, his technique was much better and we were a lot happier with the reassessment. For his 6-minute walk test, he scored 320 meters, and for his reassessment, he also scored 327 meters. The normative values for this test is 527 meters. This would give him a poor score. However, some factors need to be taken into consideration. One, that he only has 10-meter laps at his home, causing more turnarounds. Also, his RPE was very low, meaning that he can't push himself to score more meters. The warm-up was comprised of 2 exercises. 1, the recumbent bike on level 2 for 5 minutes. This was due to the corn developed on the left hallux. Usually the client would warm up on the treadmill, however, reported pain on the toe-off phase, therefore moved the first exercise to the recumbent bike. This is a good exercise for a warm-up as a low-moderate intensity warm-up to elevate the heart rate. The second warm-up exercise is walking marches. He does 5 10-meter shuttles with a different type of walking every time. It also adds a walking element in the warm-up as the lack of toe phase means the client reports little to no pain. The first exercise on this program is a Swiss ball serratus wall push. This exercise is prescribed to activate the serratus anterior, which help upward rotators to coordinate in scap control. This is the most mentally challenging exercise, therefore we prescribe it first whilst the fatigue levels are low. This is done with the purple Swiss ball, and it has 3 sets of 10 anti-clockwise rotations and 10 counterclockwise rotations. The next exercise is a single arm TheraBand row with a thoracic rotation. This is done with an orange band and 3 sets of 10 reps each arm. This is prescribed to activate lower and middle trapezius fibers, which along with the serratus anterior in the previous exercise are also important muscles in scapular control. This is a good assessment to look at scapular control through the subjective and objective information from the client. This is prescribed to strengthen the upper body large muscle groups and increase upper strength, which will assist him in his everyday ADLs. During this exercise, we also use it as a chance to assess the shoulder girdle. The next exercise is sit to stand with beam support. This is done with a body weight with 3 sets of 8 reps. The idea with the beam support is to use it as least as possible. However, if it is needed to complete the last couple reps, then it is encouraged to do so. Whilst the client is performing the sit to stand, we also use this as an opportunity to assess the ankle, knee and hip joints. We finish the day with boxing, which entails 2 sets of 50 jabs, 50 hooks, 50 uppercuts and 50 seated overhead punches. Also, through high intensity interval training, it is one, time efficient, and we get the physiological effects that we're chasing. And most of all, as opposed to other forms of cardio exercises, the client really enjoys boxing. So it's important for us to keep the type of boxing different and fresh every time, so we keep that interest going. DW's goals were the main focus when planning the exercise sessions: to decrease pain in the short term with the knee condition and long term with gait, which is affected by his previous stroke. Initially, the client wasn't confident and hesitant towards my programming and delivery. I believe this was due to previous experiences with previous EPs and the fact that I was a student. Also, DW showed signs of frustration when the exercises were isolated and the impaired left side showed considerable weakness and early fatigue. To address these issues, I was forced to be very confident not only in my programming and knowledge, but in my communication and delivery to the client. Constantly reinforcing to DW that there is a reason that there is completing these every exercise, why he's doing the exercise, and how it will positively progress him towards his goals in the future. I can relate to DW through my experiences playing rugby. Throughout my playing years, I've come across exercise scientists and physiotherapists that have clearly shown very little to no interest in myself nor pride or continued development in their profession. I understand the immense frustration this can cause, especially if you're giving a lot of time and effort into the program. In consequence, there is also hesitation in fully committing into a program delivered by a new person in that particular role. Because of this, I felt I could empathize with DW's previous experiences. The underlying factor of the issue was the effect DW's condition was having on his ADLs. Due to his balance and impaired left side function, he is placed at high risk of falls. This is partly the reason DW receives home visit sessions along with his PTSD, his inability to perform everyday tasks. Impaired balance is accompanied by an increased risk of falls and can lead to a decrease in ADLs. This can then lead to depression. Therefore, I ensured that DW was aware that the balance exercises are safe, and I had purposely prescribed them in a way where there is a way he can aid his balance if need be. If I were to come across an issue like this again, I would approach it in a similar way. I would make a greater attempt to use my interpersonal skills from the very beginning. Identifying the issue earlier may have made it easier to build rapport quicker. I feel if I did this better, then I would receive less resistance and more cooperation from the beginning, rather than trying to win the client over before making progress.